Blood transfusion is one of the most commonly used therapeutic modalities in the hospital setting. Overutilization of red blood cells leading to blood shortages is, however, a common problem worldwide. To circumvent this problem, the use of red cells should be rational so that it may benefit the patients who truly need this vital treatment. Save the blood so that it can save lives. When is red cell transfusion necessary? Good day to everyone. My name is Dr. Eric Talavera, a practicing adult hematologist, and in partnership with the Division of Hematology of the Philippine General Hospital, I would like to welcome everyone to my presentation. The objectives for this presentation is to review the available red blood cell preparations and specific indications, and to discuss and present the current evidences on red cell transfusion threshold and triggers. The red blood cell product has a usual final volume of 300 milliliters. Around 190 ml of this is due to the actual red blood cells. 20 ml is due to the plasma which remains from the original whole blood. The rest of the volume is attributed to the additive solution. The final hematocrit of this product is at around 80%. It is stored at a temperature of 1 to 6 degrees for up to 42 days. The patients needing red blood cells are greatly heterogeneous in terms of their indication for transfusion as well as their clinical characteristics. Various preparations and modifications can be therefore done for the packed red blood cells to specifically tailor to some of this special population with the overall goal of minimizing transfusion-associated complications. Each unit of packed red blood cell contains approximately 2 to 5 billion white blood cells. These white blood cells may contribute to various adverse events such as febrile non-hemolytic transfusion reaction, human leukocyte antigen alloimmunization, and transmission of cytomegalovirus. Leukoreduction, therefore, is performed by selectively removing the white blood cell by passing the blood through a reduction filter. This can achieve a 99.9% reduction in the white blood cell, leaving the unit with a final leukocyte count of less than 5 million, thereby significantly decreasing the previously mentioned risks. Indications for leukoreduced packed red cells include those who are under a chronic transfusion program such as transfusion-dependent hemoglobinopathies, patients with a history of febrile non-hemolytic transfusion reaction, those who are undergoing cardiac surgery, all recipients and potential recipients of solid or stem cell transplant, individuals with acute leukemias and other malignancies, and cytomegalovirus seronegative patients. Despite the higher upfront cost of leukoreduction, it has been suggested that it is less than that which can be incurred in treating the complications of using non-leukocyte-reduced blood. This notion has led to the policy of universal leukoreduction, which is now standard practice in many developed countries. In a resource-limited setting such as the Philippines, routine leukoreduction is not being regularly done and is mostly limited in hospitals with a relatively well-equipped and trained blood bank facility. Leukoreduction can be performed at the time of blood collection, prior to storage, or at the patient's bedside during the actual transfusion process. Pre-storage leukoreduction is preferred since it facilitates removal of intact white blood cell and avoids accumulation of cell fragments and cytokines. Cytokines may freshly leak during bedside leukoreduction, hence there have been instances of hypotensive reaction occurring during this process. The process of storage after leukoreduction also facilitates the release of potentially present intracellular organism, thereby decreasing its risk of transmission. Lastly, pre-storage reduction allows performance of quality control by measuring the level of white blood cells remaining in the unit, thereby ascertaining the efficiency of the filtration process. Red blood cell units can also be irradiated prior to transfusion by subjecting them to 2,500 centigrades of irradiation with the purpose of inactivating viable lymphocytes. Irradiation sources include gamma rays from either a cesium or a cobalt blood irradiator or X-rays using a standalone machine. Viable donor lymphocytes can attack recipient cells in individuals who are unable to mount an immune response against them, causing what we call a transfusion-associated graft versus host disease. Prevention of this complication is the primary indication for using irradiated red cell products. Red cell units that have been irradiated have its shelf life decreased to 28 days due to a higher potassium concentration. The British Committee for Standards in Hematology has released the following patient population wherein irradiated packed red cells may be indicated, and these include the following. The recommended duration to use irradiated red cell products is variable, ranging from indefinite, such as those individuals with Hodgkin lymphoma or congenital immunodeficiency disease, to time-limited, such as those who underwent autologous transplantation, have a duration of 3 to 6 months, or as long as graft versus host disease is present in cases of allogeneic stem cell transplantation. Randomized trials comparing irradiated units versus non-irradiated units have not been performed. Immunocompromised patient groups have been defined based on observational evidence, case reports, and reviews. Thus, there is a lack of consistency in the literature as to which patients actually must receive irradiated blood. Washed red cells is done through an automated system using an isotonic sodium chloride solution. Washing serves to reduce or eliminate complications associated with the small amount of residual plasma in the unit. It may also reduce white blood cells and platelets in the product, but it is not as efficient nor can serve as a substitute for leukoreduction. The shelf life of washed blood is 4 hours if stored at 20 to 24 degrees Celsius or 24 hours if stored at 1 to 6 degrees Celsius. The indications for using washed red blood cells are limited to those with a history of severe and recurrent allergic reactions due to blood transfusion, those with absolute immunoglobulin A deficiency, and those who are at risk for hyperkalemia. Volume reduction is a simple process wherein the final volume of the red cell unit is reduced. It can be performed by centrifuging the unit immediately prior to transfusion in order to remove the additive solution. The final volume usually ranges from 300 to 400 ml. Aliquoting, on the other hand, refers to splitting the units into different satellite bags or alicos. The overall goal of both of these processes is to reduce the overall volume of the unit. The shelf life for volume-reduced red cells is approximately 24 hours and is stored at 1 to 6 degrees Celsius. The indications for using volume-reduced red blood cells are limited to a subgroup of patients who are deemed at high risk for circulatory overload with a standard unit. Good examples include those with congestive heart failure, renal failure, and those with extremes of age. Although there is still no definite evidence of this, volume-reduced red blood cells or split units may be considered for individuals with acute leukemias who have hyperleukocytosis but has concomitant severe symptomatic anemia, in order to mitigate further increasing blood viscosity, which has been brought about by the elevated leukocyte fraction. For the next part of the lecture, we will now be moving on to the current evidences for the triggers and threshold of red cell transfusion. Optimization of red cell transfusion is vital, wherein the goal is to maximize clinical outcomes while avoiding unnecessary transfusions leading to adverse events. It is also important for clinicians to understand that transfusion, although life-saving, is merely a short-term treatment. It is not a substitute for specific treatment directed at the underlying cause of anemia or bleeding, which must be addressed accordingly. If transfusion is strongly considered, the threshold to perform it should be based on a combination of objective evidence and clinical judgment. Factors that need to be considered include the present hemoglobin level, clinical symptoms and status, presence of comorbidities, and the patient's individual wishes. For the succeeding slides, we will now be discussing the transfusion triggers for different patient population who have anemia or blood loss. For stable medical and surgical cases, the latest consensus is to proceed with a restrictive transfusion strategy rather than a liberal. The main criteria to define stability includes asymptomatic patients, no clinical or laboratory evidence of ischemia, normotensive, and those who are not actively bleeding. Restrictive transfusion is preferred for this large subset of patients with a threshold to transfuse at a hemoglobin level of 7 to 8 grams per deciliter. The recommendation to proceed with such consensus was made on the basis of different randomized clinical trials that were done in the past few years. The restrictive threshold in hemodynamically stable patients in the ICU is supported by data from the TRIC trial. Compared with the liberal transfusion strategy, overall 30-day mortality favored the restrictive group, but was not statistically significant. There were two subgroups, however, wherein the mortality rate was significantly lower, and these were the less severely ill patients with an Apache score of less than 20 and those less than 55 years of age. The use of restrictive transfusion for surgical cases were primarily based on the results of the FOCUS and the TRACS trial. The FOCUS trial aimed to determine the optimal threshold for perioperative transfusion in hip fracture repair, while the TRACS trial involved patients who underwent cardiopulmonary bypass. Both studies showed that there was no significant difference in the primary endpoints between the restrictive and liberal approach. However, the number of transfusions correlated with clinical complications. For patients with septic shock who have no evidence of active bleeding or myocardial ischemia, the TRIS trial showed that a hemoglobin threshold of 7 grams per deciliter was safe and favored on the basis of a similar 90-day mortality rate when compared with the liberal strategy. Other outcomes such as ischemic events, transfusion reaction, use of inotropic therapy, and need for mechanical ventilation were also similar between the two groups. The decision whether to transfuse patients with cardiovascular disease should be dependent on the nature of the disorder. The Reality trial, published last 2021, randomized adult patients with symptomatic myocardial infarction and anemia to a restrictive and liberal transfusion strategy. The restrictive group had a lower incidence of major cardiovascular events at 30 days and was non-inferior. However, long-term follow-up after 1 year showed more frequent cardiovascular events in the restrictive group. This study also has several limitations, most significant of which was its moderate size, and thus it was not powered for evaluating the superiority of either strategy. Taken in aggregate, these short and long-term findings from the Reality trial indicate that the relative safety and efficacy of the two transfusion approaches still remain unanswered. The ongoing myocardial ischemia and transfusion trial is evaluating 3,500 patients with acute coronary syndrome and is powered to answer the transfusion threshold question in this population. The estimated completion of the study is around October of this year. For patients with stable coronary artery disease, there is a lack of data from clinical trials to guide us on the appropriate transfusion practice. Most experts consider the threshold of 8 grams per deciliter as safe for asymptomatic cases. Transfusion for symptomatic cases should be guided by the symptoms and clinical judgment, since it is difficult to discern if the said symptoms are predominantly due to anemia or from the coronary stenosis. Similarly, transfusion thresholds in heart failure are based on low-quality evidence. Most experts consider the threshold of 7 to 8 grams per deciliter as safe with careful attention to the volume. Clinical judgment should be used for symptomatic patients since it is also difficult to discern if the symptoms are predominantly due to the anemia or from the underlying heart failure. Acute bleeding is an especially challenging clinical setting in which to evaluate transfusion threshold. For patients with massive bleeding and hemodynamic instability, the threshold to transfuse should be based on hemodynamic parameters, the pace of bleeding, and the ability to localize and control the bleeding rather than relying on a specific numerical hemoglobin value. On the other hand, for hemodynamically stable bleeding patients, a restrictive strategy with a threshold to transfuse once hemoglobin is less than 7 grams per deciliter may be employed based on a randomized clinical trial involving patients with acute upper gastrointestinal hemorrhage, wherein outcomes were improved in the restrictive arm. It is important to note, however, that in this study, all patients were able to undergo emergent endoscopy within 6 hours of bleeding onset and were also treated with endoscopic therapy. The findings in this clinical trial may be applied to bleeding from other sites, provided that hemodynamic stability is maintained, the patient is not at risk for complications, and there is rapid access to surgical intervention when needed. For cancer patients, the approach to blood transfusion may differ depending on the goals of therapy. There are currently no adequately powered clinical trials comparing the restrictive with the liberal approach. Based on expert opinion, patients undergoing cancer therapy with curative intent who do not have severe thrombocytopenia should be transfused similarly to a stable medical patient. For patients with symptoms and a hemoglobin of greater than 8 grams per deciliter, clinical judgment should be employed. For those with severe thrombocytopenia attributable to the myelosuppressive nature of their treatment, transfusion may be considered to maintain hematocrit at greater than 25% to reduce the risk of major bleeding. There are no specific guidelines for threshold among patients receiving palliative care since the primary goal is centered more on hospice and quality of life. The threshold to transfuse may be done on a case-to-case basis and should be in accordance with the patient's directives and desire. Patients afflicted with hematologic disorders requiring regular and chronic transfusion may need different thresholds. For those who have transfusion-dependent thalassemia, regular transfusion every 2 to 4 weeks alongside iron chelation is required to maintain pre-transfusion hemoglobin above 9 to 10.5 grams per deciliter. This is in order to suppress intra- and extramedullary hematopoiesis, hypercatabolism, and support normal growth in children. For thalassemia patients with cardiac complications, a higher threshold of 11 to 12 grams per deciliter may be needed. For those with immune hemolytic anemia, a combination of factors must be considered. Of particular importance is the rate of hemoglobin decline due to hemolysis. Hence, even if the patient is asymptomatic, but the rate of decline is more than 2 grams per deciliter per day, preemptive transfusion may be considered on top of specific therapy. If the decline is less than 2 grams per deciliter per day, the threshold to transfuse is same as stable medical patients. Aside from the ones mentioned, there are also other distinctive patient population where there is positive data to help guide us in determining the most appropriate transfusion threshold. Examples are those with cerebrovascular disease and other neurologic disorders, traumatic brain injury, and vascular surgery cases. In the absence of data, experts suggest to set the threshold based on their location of care or on the similarity of their underlying disease to that of a patient group where data are available. In most cases, a hemoglobin threshold of 7 to 8 grams per deciliter is considered appropriate. Having discussed the different patient population and their corresponding threshold, let us now synthesize everything using an algorithmic approach. The presented approach may not be applicable to those with underlying hemoglobinopathies. The decision to transfuse should always begin with a clinical and laboratory assessment. Determination of hemoglobin value can be utilized as a pivotal point in the process. For individuals with a hemoglobin of more than 10 grams per deciliter, the value should be interpreted in the context of a rapid hemoglobin decline of more than 2 grams per deciliter per day, the presence of active bleeding, and hemodynamic instability. If the following are present, blood transfusion may be considered. If not, it should be omitted. For patients with a hemoglobin value of less than 7, transfusion is indicated regardless of the presence of symptoms or the patient's clinical stability, except for rare exceptions, such as religious beliefs which prohibits blood transfusion, such as those in Jehovah's Witnesses. For patients with a hemoglobin value between 7 to 10 grams per deciliter, assessment for any evidence of ischemia, hemodynamic instability, or symptoms that may be attributable to anemia should be undertaken. If none are present, it is recommended to follow the transfusion threshold set forth by different clinical trials and expert opinion. If present, transfusion is appropriate if the hemoglobin is less than 8 and may be considered if it's between 8 to 10 grams per deciliter. This table summarizes the recommended hemoglobin threshold for different medical and surgical populations that we have previously discussed. It is important to remember that the threshold should always be correlated with the patient's current clinical and hemodynamic status. Therefore, clinical judgment is very important. We are currently near the end of this lecture. The following are the important learning points that I wish to impart. Red cell transfusion is a vital therapeutic modality that serves to enhance oxygen delivery in anemic or bleeding patients. There are various preparations and modifications which has its unique indications and is beneficial for the intended population. The process of transfusion should be optimized with the goal of maximizing the desired outcome and minimizing adverse events. Red cell transfusion is and will always be a short-term treatment for most cases, and it does not serve to replace the specific therapy for the underlying cause. Various thresholds have been set in place in order to help direct physicians to a rational and restrictive transfusion practice. However, despite this, there is still limited data in some patient population. Blood products are invaluable in improving the clinical status of patients in need. This has led to various directives to the general public to do their part and donate blood. The phrase "give blood, save a life" has been repeated in more times than can ever count. However, as members of the medical team, we must also do our own part. The adequate supply of blood will be of no value if we continue to administer it haphazardly. The slogan "Give blood, save a life" should always be complemented by another phrase. Use blood wisely. Save the blood so that it can save lives. Good day, everyone. Again, my name is Dr. Eric Talavera, and I do hope I was able to impart something worthwhile and relevant with this brief discussion. These are my references. Thank you and good day.